in Ethiopia, and it has been operating since 2010 in that ballpark. So pretty well established group at this point, and I think it's somewhat of a unique collaboration, at least in the School of Public Health, sort of really building on relationships between faith communities, public health practice, and sort of partnering with our colleagues in Ethiopia to do a lot of just on-the-ground work. The focus of SCOPE has been on providing opportunities for University of Washington fellows to collaborate with fellows at the University of Gondar to explore different opportunities to promote public health in general, with a real focus on maternal-child health most recently. SCOPE has evaluated and sort of developed some models of partnering faith leaders in Ethiopia with public health professionals, especially members of what's called the Health Development Army, which are often referred to as community health workers in other settings, to sort of use the influence and community relevance of the faith leaders in primarily the members of the Ethiopian Orthodox Church, and sort of partnering them with health workers to reach out to the community to promote things like antenatal care, facility deliveries, and postpartum care and early child development. Most of the work has been focused on sort of supporting fellows, and the funding for these fellows comes from fundraising and donations, primarily organized through the University Presbyterian Church. So we run a very tight ship, and I think it's been a great opportunity for the fellows that hopefully we'll hear about today. And go ahead and go to the next slide. In addition to the fellow-based work, SCOPE has gotten some funding both from the U.S. government as well as from some foundations to conduct some small-scale randomized trials. So we've done both community randomized and individually randomized trials looking at this model of partnering, and have shown promising results in terms of promoting antenatal care attendance, facility deliveries, and some newborn care outcomes, like as Dieudonné just presented in his dissertation work, promoting exclusive breastfeeding over the first 6 months. So I think I'll wrap up there. Dieudonné, anything else you want to say about SCOPE? Okay. So Hiwot and Brooke were fellows this past year, and this also represents I think a new area for SCOPE. As I mentioned, most of the work that we've focused on up to this point has focused on advocating for service utilization. And they branched out and sort of leaning on the global mental health expertise in the Department of Global Health and responding to emerging needs that were highlighted by our colleagues at the University of Gondar. So I will turn it over to you guys.
Can you hear me, right? Yes. Yeah. As Brandon mentioned, so SCOPE works with the University of Gondar in Gondar, Ethiopia, as well as the Ethiopian Orthodox Church. So we usually get some idea for intervention. So that's how this meta-analysis format research came up, because of the ongoing conflict in Gondar. Was the church and the University of Gondar mentioned to SCOPE. I think there is emerging problem that we're seeing, and we want to study what's going on and provide, come up with some kind of intervention. So that's how I traveled to Ethiopia to do a very informative research, to talk to the people on the ground and understand what is happening. So that's what I will be presenting today. So I will talk about the background, the methods, and everything. Just to give you some idea what's going on in Gondar and overall in Ethiopia, there is a civil war that's happening. It starts in 2020, that was in the Tigray region, and then it moves to Gondar in 2022. This is like a war between the federal government and the regional government, like the regional militia and then the federal government, because of some kind of reason. So this is just a civil conflict that's happening. And unfortunately, due to that, we have more than 5 million people displaced internally, living in shelters all over the places. And we have, I think by now the number might be increasing, more than 500,000 people dying, mostly the youth, children and mothers. And then there is a widespread exposure to violence, insecurity that's happening in the northern part of the country. That disrupts daily life, including education, the socio-economic structure, the market, all sorts of problems happening. And because of that, there is trauma-related depression, PTSD, and anxiety. So part of the fellowship that we did was to review what has been published or researched back in that area. So myself and the fellow from the University of Gondar, Balgatu, we did a literature review. I think we reviewed more than 15 papers that came out even in that particular region. And what we found was there is really a huge prevalence of PTSD and depression, more than 51%. And then what is the most terrifying is there is a gender-based violence that's coming more than 40%, mostly impacting women and girls in the IDP in shelters. And then there is suicide and suicidality impacting the venues. So these are the questions that I was trying to answer using this format of research. The first one is to understand what are the common mental health challenges that we're seeing. Is it depression? Is it PTSD? So just trying to identify that. And then also to help us in providing intervention, which I know everyone is impacted, but which of this segment are highly impacted. And also understanding the help-seeking behavior. And finally, identifying if the intervention opportunity that we can work on, and also the stakeholders. What are the stakeholders? Is there any intervention? If not, what can we provide or do intervention? So in this format of research, we just did a qualitative study, talking to people over the phone, interview. We did a purposive sampling of 30 participants coming from the 6 stakeholders. This includes parents, youth, church leaders, youth leaders, Sunday school, and healthcare workers. So the fellow back in Gondar, Balgatu, did a lot of work on this one. He had to go, meeting people to the church. He almost did everything in terms of picking, individuals, recruiting, using the community network that the school has, the church, the youth center. And then we were able to find finally 31 individual. And then we did in-depth interview and key informant interview that took us almost a week over the phone. So the median time of talking was almost 1 hour, but there was a time that we had to talk an individual almost 2 hours, to go through the question. So yeah, this is the overall domain of the question that we asked. Even though we have different stakeholders, which means we had to adjust some of the questions, but overall, our interview questions involve, what are the perception of mental health? How are they defining the key challenges that's coming due to the conflict? And then we want to know from these individuals who are the mostly impacted group. And then what is the cultural belief in terms of understanding the mental health, the role of religion in health seeking, and everything. And then also understanding the stigma and barriers due to mental health, because that is really stigmatized in our community. And then what are the coping mechanisms that people are using right now, because there is a lot of distraction, there is no healthcare system that we can see that's providing care. And then the service gap, so that we can identify opportunity to improve support. So yeah, when we get this question set up, I got a lot of help from Anna, Kasha, to solidify the questions. So yeah, this is, so just to give you a highlight of the results, even though we were planning to do 30 in the interview, we ended up getting 31 individuals. We did 10 of them in-depth interview and 21 key informant. So most of them, 55% are female, and then the age range is 21 to 50. Because we didn't have any IRB, we weren't able to ask them personally, identify with questions. So this is just our educated guess in terms of estimating the age and the gender. So for the first question, what are the common mental health challenges? This is almost unanimously reported by all the individuals. So the first one was PTSD. There is really high prevalent PTSD, depression, anxiety, suicidality, and substance misuse that is happening because of the conflict. And then even the existing, depression, there is increase in severity of depression. Found that depression is really increasing, and there is, a widespread trauma exposure due to the violence that includes displacement, gender-based violence, which is the most emerging one. And then the most concerning, particularly impacting the use males, is substance use. That includes alcohol and chat. Chat is it's a green leafy things which is equivalent to marijuana in this country, so that people chew. It has high nicotine and very addictive. And then there is also suicidality. So these are the challenges that we identified through the interview process. Yeah, and then looking at the most impacted group, obviously because of the sexual violence and suicidality, girls and young women are highly impacted. And then the second one is the youth, mostly the men, because they had to, go and fight. That's the civil war is like recruiting the youth, the young boys, to fight with the federal government. So there is a huge psychological distress, trauma, hopelessness, and suicidality, including the substance use as well. And then the other one, which is really terrifying, is children. There is anxiety and fear of abduction. So what's going on is because there's no law and order, the militia or some people who are like have this gun and everything, they are taking children's, mostly targeting children's who are coming from the rich individuals, so they can ask for money. So they will ask for ransom, which is like huge amount in millions of Ethiopian birr. And then if someone fails to provide that, they will kill us. This is really terrifying thing that's happening. And then there's the disruption of education. There's no school in particularly the rural area of Gondar. There's insecurity. So children are really having a hard time. And for them, it's really difficult to even get help because they don't even know what's going on. And this is impacting the parents, which I will provide some of the quotes that I got during the interview. And then obviously the displaced population, there is a very limited access in mental health, not only mental health, even food, clean water, sanitation. So because they live in a shelter in tent, those 5 million people, so there is a lot of problem, including mental health. So I just want to share like some of the quotes that I found, which are really like heartbreaking, and it shows like the problem. So this one is from one of the parents, which I just mentioned earlier about the abduction. So how parents are really terrified because of their children. And then this woman mentioned that this is really the hardest part hard part to be a parent. She said that she's 35, she's young, but she's terrified about her children. And these children never chose to be born into the world. They have heard about child abduction and kidnappers demanding for money, and if families can't pay, they kill the children. So my kids no longer go to school because there's a disruption, and they can't even play outside for fear of the gun. There's a gunfire that's going around. They hardly sleep. They wake up screaming from nightmares. I find some pieces talking with my neighbors and our priest. This is like how the social interaction is helping with some of the parents. But my children still don't know how to cope. It breaks my heart that I can't protect them from this terror. So this is just one example, but you can imagine like every parent is going through this kind of thing, mostly because of their children's, in addition to what's happening to their own life as well. And this is one of the youth that we spoke with. I think with this individual, we spoke almost 2 hours because he has been going through a lot of problem. So he mentioned about what's happening for the youth. He's in high school, so the school is shut down, it's closed, and then there's gunfire and then everything everywhere. The only choice for the youth seems to be joining the fighters and fight, be in the war, or staying and hiding at home. So he said that I chose to hide, but it feels really suffocating each day. I feel with dread about what might be tomorrow, what tomorrow might bring. Some of my friends left Gondar, and a few even died at the sea trying to find a better life. So that one of the coping things that the youth are doing is instead of fighting, they flee the country, and then they go from Sudan and Libya, and then there is a Red Sea to go across to Italy. You might have heard a lot of news coming because they use small boats and they are sinking. So he heard about those. He said that instead of staying here and being suffocated, I would rather go and die with my friends. And then he said that because of all these things, he started drinking and chewing jam to numb the fear, but it's not helping. I feel trapped and I don't even how to escape this darkness. So this is really heartbreaking. And we also talked about the faith leaders. These are like the most important individuals at this time who are providing help and support to the people. People really, they don't have any choice, but they go to the faith leaders. So these faith leaders we spoke, he said that the situation is really dire. Our only true hope is God, and we are all turning to Him. Every day more people are coming to us with deep trauma and mental health burden. Our holy water sanctuaries are overflowing, but most of our priests don't know how to respond to depression or anxiety. So we are offering prayer and blessing, but this is not really enough with what we are seeing. So yeah, he said this mental health is really stigmatized. It's just showing the gap that exists. People are using the healing, the prayer, but this is not enough. We have really a large number of people coming for help. They don't even know how to provide that kind of support. And we also try to understand the help-seeking behavior. If our people, going and asking for help, but there's a lot of things that's impacting the help-seeking. One is the barriers. The healthcare system is disrupted, so most of the facilities are destroyed. Healthcare workers are either sitting at home or they flee because of that. There is also very limited culturally appropriate services. There is a huge stigma when it comes to mental health. If someone came on and say I have depression, they might say, this individual is crazy. They will be labeled. So because of that, people, they don't really seek help. And there's also a fear of social consequences, especially for the gender-based violence survivor. They don't really come out and say, I am a victim and then I need help, because if they do that, they will be stigmatized, and in that rural community they may not have someone to marry them. But there's a lot of social stigma that's going on. And the other thing in terms of help seeking is they use other coping or resilience strategies, which is the prayer, the spiritual pathways. That's the other way they are getting most of help in addition, instead of the medicine or the other routes. And the last one, which is the most terrifying, is people are using the maladaptive coping. Especially they use, instead of help seeking, they use substances or risky migrations. So this is what we found in the help seeking. So the last one will be intervention opportunity. We asked if there is any intervention or anything that's happening. We couldn't find anything tangible that's going on, except what the faith leaders are providing, through the holy water, the prayers. There are some kind of intervention by the international community that's mostly on the IDP or the displaced individual, but the normal community, there is no intervention. So we talked with these participants to ask them, if they have any recommendation, what kind of intervention can we provide. So these are what we came up with. At the community level, if we have intervention that increase awareness through, local TV or radio, mostly it reduces stigma. So we can work with community leaders, religious leaders, teachers, the media, to tackle this intervention. And then the other one is intervention at the health workers level. You might know, in Ethiopia, we could have one psychiatry doctor in a big hospital. So that's the only thing that we can find. Psychiatry nurses are really rare, so we can do task shifting, like training the healthcare workers to also take some of the works. So that will be another intervention opportunity that we can do in healthcare workers, which we can work with the Ministry of Health, the clinics, the hospitals, in providing short-term training and do the task shifting. And the other one will be the linkage between community institution, the community and institution, which we see that this will be the ideal for SCOPE, because SCOPE works with the faith leaders, and faith leaders are the most trusted individual, and then they reach really remote area people. They have a well-established infrastructure that none of the system has. So we can use that and then do the referral pathways. So when they talk to their parish individuals, if they see any sign of depression or anxiety, we can use that as a link to get access to the healthcare system. So this could be working with healthcare provider, the religious institution, community organization. And then the last one, obviously, a national level policy intervention that includes at the national level task shifting, training for healthcare workers, which requires a broader intervention. So yeah, to conclude, the conflict has led a lot of trauma, depression, anxiety, PTSD in the community, and women and youth and displaced individuals are disproportionately impacted by this ongoing conflict. Help-seeking behavior is really limited because of access barrier to access and relying on informal and spiritual supporting system. And then stakeholder identified that the need for a multi-level, culturally grounded intervention, integrating the community, health system, the church. So the last one, after I did that for my research, the next thing what we did was I moved back here, and then we developed a survey that includes a lot of the validated tool like the PCL, PHQ-9, and then also adding assist like to measure the substance use. And then we had a couple of intervention ideas, including the friendship bench, which has been proved to be very effective in so many African countries. And after we developed that, so the next phase will be for Brooke to go back to Ethiopia. This is just one of the things that we did, but she did a lot of things to validate the assist and then also to pilot some of the part of the survey that we developed together as a team. So with that, I will.
Yeah, thank you so much, Hiwot, for the introduction and doing so much of the groundwork into my fellowship. So I'm going to be sharing my fellowship experience with Scope from this past summer. I was in Ethiopia for 6 weeks, and the main point of discussion I'll be talking about today was looking into substance use and mental health with REDCap tools in Ethiopia. So here's just a brief overview of my presentation, and I'm going to jump into my main aims of my practicum and fellowship experience. So I had 4 main aims of my Scope fellowship, but just for the sake of time, I'm only going to be talking about the first 2, which was on the REDCap tools. So the main goals of the REDCap surveys was first to validate a substance use survey tool in the Ethiopian context with cognitive interviewing, and second, to pilot a survey on mental health treatment preferences in the community, including friendship bench. So I just wanted to start with this slide. Local idioms of distress are really important and foundational in global mental health work. So just to define this concept, idioms of distress are alternative modes of expressing distress and manifestations of distress with relation to personal and cultural meaning. So in a paper by Deepa Rao of our Global Health Department, she discusses the importance of integrating local idioms of distress in mental health care delivery. And this includes screening tools in order to accurately diagnose and capture the burden of mental illness in communities. So through interviews and literature, we found what the local idioms of distress were in Ethiopia, which was especially important for me because I lack lived experience in that setting. So first and foremost, distress is often experienced and presented physically or somatically through headaches, fatigue, and body pain. And this was very common for women to express symptoms of mental illness in this capacity. And additionally, anger or irritability may replace other symptoms of mental illness like sadness. And then I think the last 2 bullet points on this first part of the slide are the most important in understanding mental illness in Ethiopia, which is that it's often understood in a social or spiritual lens. So people can think of the etiology of mental illness through possession, the result of sin or demonic influence, and then also as a result of interpersonal conflict. And as Hiwot mentioned, mental health is a very stigmatized and taboo topic. So it's not common that it's openly discussed or talked about. And then these are some phrases that were translated into English that kind of show how mental health is actually discussed in Ethiopia. So people would describe burning sensations in the head, which shows the somatic representation of mental illness, thinking too much and wounds to the soul, or gut twisted to its core, kind of just showing other expressions of symptoms. So I show that because it's really important in setting up for the REDCap survey work that we did to make sure that we were using the correct language and understanding really how this was discussed and talked about. So the first step in our validation of the survey was on cognitive interviewing of the alcohol, smoking, and substance involvement screening test tool. This is an international screening tool for substance use developed by the WHO, which was supposed to be a culturally relevant mechanism of evaluating substance use. However, there was actually not a lot of literature evaluating how this was adapted in the Ethiopian setting. So our goal was to determine how this would be validated in Ethiopia and what changes could be made to the survey. So just to define cognitive interviewing, this is a qualitative method where participants take a survey to verbalize their thought processes on answering questions. And the main goal is to improve comprehension, wording, and enhance accuracy of responses from participants. So we validated this survey and did cognitive interviews with 10 adults. The nature of my fellowship was really interesting because typically SCOPE works in the Gondar setting, but because of the conflict that Hiwot discussed, we were based in the capital city in Addis Ababa. So we often had to do in-depth interviews through remote methods over the phone, or did a few in person as well. But these remote interviews would then be translated by WACh, who I also worked with, and then uploaded into REDCap Mobile to make sure that the dynamics of our survey were working, and then uploaded into our REDCap survey online. So some of the questions that this survey asked was, have you ever used certain substances? How often have you had a strong desire to use these in the past 3 months? And then have you ever had any problems arise from your use of these substances? So now I'm just going to outline some of the findings that we saw through these cognitive interviews. On the left is going to be an example of a more Western assist substance use screening tool. This one was specifically used in Oregon. And then on the right is our survey that we were piloting in Ethiopia. So hopefully you can see that. But one of the most important findings was to actually use local and more traditional substance terminology. So when we would ask these questions about substance use, if we use just alcohol, a lot of people weren't super familiar with this, especially if they were located in more rural regions or had lower literacy. So we changed them to more locally appropriate terminology, with one example being tej, which is a honey wine that's commonly used in Ethiopia. So for this next slide, we had a lot of recommendations on certain language to change, again, especially for individuals that were in more rural settings. So one of the questions was asking about having a strong urge to use substances, kind of getting at the craving aspect. And this was not coming across clearly at all when we were asking this question. So people recommended we changed it to a strong desire. And we had a few other questions in the survey that were recommended to be altered just for coherence sake. So this was an important finding for us. And then lastly, we had a lot of recommendations to actually contextualize our questions with more local examples. So substance use is often tied to cultural holidays or festivals in Ethiopia and religion as well. So in this question, the question was, how often have you failed to do what was normally expected of you? And we were recommended to add actual examples of what social and cultural expectations were of individuals in Ethiopia. So this included work, family, and religious responsibilities. So just in terms of some of the broader themes of validating and conducting cognitive interviews on this assist tool, we saw that ceremonial use was very common in substances, and these were often tied to cultural and communal practices like religion, holidays, or festivals. We also saw a lot more broader harms that were related to substance use and misuse, like financial strain, interpersonal conflict, legal issues, and stigma. Stigma actually came out as a very important finding, especially because people often, as Hiwot said, seek care through priests or religious institutions, and they were very often stigmatized for seeking care if they were struggling with substance misuse. And there was also a lot of broader stigma and prejudice around families that were associated with individuals who were struggling. So this was important to come to understand. And then lastly, there was a lot of comorbidities in experiencing substance misuse, like trauma from experiencing the conflict, and then other mental health challenges like depression often continue the use of substances and have this as a form of coping. And yeah. And then this is a picture of tej, which is commonly used in Ethiopian community settings. I think this photo is from a traditional dance, and they often serve this. So getting into the next survey that we piloted, this was focused on mental health intervention preferences. So we were only able to screen this survey with 2 individuals, so it's a very small sample size, but our goal was mainly to just make sure that this was working. It was a very long survey, so we were just wanting to see how the survey was coming across and what some preliminary findings were of what people would like to see implemented in the community. Additionally, it was a very small sample size because Hiwot had already done a lot of informal interviews and found a lot of recommendations for mental health interventions. And then this was done with a similar method as the previous survey validation of having these done remotely, translated, and then uploaded into RedCap Mobile. And then some of the questions that were asked were, what is your preferred format for mental health support? What providers would you like to be reading this? And then what qualities would you like to be in these providers of mental health services? So some of the findings that we saw was first and foremost to prioritize safety and access to basic needs, especially during conflict. I think this was one of the most impactful findings for me because somebody said, it was a psychiatrist and global mental health researcher who works at Addis Ababa University. She shared that mental health support does not necessarily have to be one-on-one counseling. The most impactful support that individuals can receive, especially when experiencing conflict, is just access to basic needs. So this can be food, housing, healthcare, and often that would have a lot more of an impact than actual intervention in the form of counseling. But in addition to having those basic needs and more social determinants of health met, coping practices through faith and social rituals were recommended. So more culturally congruent methods that would align with faith. Coffee ceremonies are really common in Ethiopia and happen a few times a day for some. And elders are another very trusted and supported leader in the community. So individuals often preferred having these trusted leaders deliver these services. And it was emphasized that trust was very important, as well as confidentiality and having individuals that understood the local understanding of mental health being through a spiritual lens. And then this was the final piloting aspect that we focused on. So within that last community well-being intervention preferences survey that I just discussed, this was kind of a subsection that was within that larger survey that we wanted to focus on. And this was focusing on what the feasibility and acceptance of implementing Friendship Bench would be in the community. Friendship Bench, for those who aren't aware, was created by Dixon Chibanda, and he trained Zimbabwean grandmothers to counsel people with depression on park benches through simple talk therapy. And now this has been a widespread adaptation throughout other regions of sub-Saharan Africa and even in the US, and it's been seen to be very effective in getting people to be more comfortable talking about mental health and opening up more about struggles that they might be experiencing. So we asked questions about Friendship Bench to 5 adults with the same method as the previous 2 surveys that I mentioned. And some of the questions would be, what's your comfortability talking about mental health on a public bench? Would this be helpful to your community? And what barriers would you anticipate in seeking support? So in piloting these questions, we saw that friendship bench was seen as very valuable, but often limited by stigma and broader social norms. So this was more widely accepted among women, and we found that men were very hesitant about discussing mental health more openly in this way. Specifically, men and potentially older adults who wanted more faith-based mental health interventions. However, among those that were very willing to participate, we saw that they wanted this to be led by trusted facilitators. So this could be elders, faith leaders, and a lot of individuals said they wanted and preferred for this to be led by women. And then other recommendations in implementing this was to have this integrated more broadly at a structural level. And it could not just be something that was offered really inconsistently. They wanted this to be something that would be held in communities often to actually ensure there was adherence and uptake to this. And we were also recommended to focus on conducting psychoeducation in the community before actually implementing this so that people were more aware of mental health and were kind of guided into destigmatizing the topic to actually be open to using these friendship benches. And then just to wrap up, I wanted to share some of the stakeholders and organizations that we were able to meet with during our field. This was one of my favorite aspects of my fellowship. So we met with a lot of amazing institutions working on mental health and maternal health more broadly. We worked very closely with IPHCE, who focuses on primary care systems in Ethiopia, Emmanuel Mental Specialized Hospital, which is the only specialized mental health hospital in the entire country, the Ministry of Health, Hamlin Fistula Hospital, and then Healing Hands of Joy, which I'll get into on the next slide. And then we also met with some amazing individuals who are working in this field. First was Rediet Faleke, who's actually a medical student right now, but she founded Aura, which is a mental health organization focused on recovery and awareness. And this was really great because there's not a ton of global mental health work going on right now in Ethiopia, so she was very passionate about this topic. And then lastly, we were able to meet with Dr. Adelea Lem, who's a leading global mental health researcher and also initiated one of the first training programs for psychiatrists in Ethiopia. And lastly, Dr. Zeb Elamu, who is another global mental health researcher in Addis Ababa University. And then here's a slide on our Healing Hands of Joy partnership. Scope has been shifting to doing a lot of work with this organization. Healing Hands of Joy focuses on training obstetric fistula survivors as safe motherhood ambassadors. And the goal is to have these members go into the community and share their experiences about having fistula, seeking services for this, breaking down stigma on this. They also focus a lot on economic empowerment. So this can include having women who've experienced fistula start up their own businesses to get reintegrated back into the community. And they also do a lot of rehabilitation work with these individuals as well. So we were able to visit their office in Jimma, Ethiopia, and attended a faith leader training and a safe motherhood ambassador refresher training as well, and met some safe motherhood ambassadors who are graduating to go enter the community. And some exciting next steps for Scope. We have 2 new fellows. One is actually in the room right now. And one is going to continue working on our mental health work, hopefully, and the other will be hoping to continue the partnership with Healing Hands of Joy, which is more focused on maternal health and obstetric fistula promotion. And then Diodane, who's here as well, just received the UW Global Innovation Fund Award to continue an assessment of launches sustainability, which was a past project by Scope focused on maternal health education and outreach by Priests and Health Development Army, which Brendan mentioned earlier, but they are essentially a priest and community health worker dyad. So, and then Hiwot and I wanted to acknowledge Bokatu, who helped us with a lot of our work during our fellowship and contributed a lot to making partnerships in the field and helping with translation and writing. That's all. Thank you.
questions?
I'm gonna kick things off. Thank you both so much. This was so great to hear about your experiences, like beautiful slides, and yeah, such a great contribution to Scope. And one thing that I think Brandon talked about at the beginning was that Scope has traditionally focused on HIV and maternal-child health, and the genesis of your fellowships was because there was a meeting in 2022 in Addis where we were ideating like what would the next steps of Scope be, what were their priorities, and our Scope partner said our priorities are mental health given the conflict that's going on, and like this is our goal is to move into this area. But one thing that wasn't clear at that time was like how much people would be willing to talk about mental health and how to like frame those sorts of interventions and collect data, and you both have contributed to that so much. It's amazing. And I'm wondering, just kind of taking a step back, as you were approaching people for surveys and interviews, like how did that even initial approach go? Did you find people resistant to participating? Did you find that you had to kind of tailor the way that you approached people over time, and how so?
Yeah, so maybe I can speak for myself. Because it's unfortunately we had to meet with them over the phone, right? I was in Addis, but that we did a lot of heavy lifting. We had to go sometimes to their home to make them like comfortable, and then call, and then it will make me join the call after everything's done. But yeah, obviously there's a lot of resistance when it comes to like talking about mental health. There's a lot of that's one thing that we noticed. And for me, I can speak the language, so and then I took a training a mental health first aider, so I have like some kind of perspective. Like mostly, I was just listening. Some of the conversation. It looks like a mental health counseling session because they would be like speaking even something that's not related to the question that we asked them. But I think the one thing that I learned is like just listen. Yeah, it's not about the time, or it's not about like my questions being answered, but I would just take time and then listen, which will help with that. But yeah, there is a lot of resistance. But the one thing that helped is WACh is really, really well connected. He has people in the church. He's also related to the church community and he's educated himself. So that connection helped him. And also going to the place where they are, in their house, or in a place they feel comfortable, that makes it more easier. But I wish I was there in person and see like how they react, how they feel. But
yeah, I would echo everything that Hiwot said. WACh did a lot of the heavy lifting, especially for me because I don't speak Amharic. So he was really helpful in making sure that the conversations were very open, and I think listening is also key. And for me, the reason I talked a lot about local idioms of distress was that was a really important first step in approaching those conversations, to kind of take my more Western biases out of talking about mental health and making sure I'm on the same page of having the same conversation in the way that mental health is understood in Ethiopia. So that was helpful for me. But I also think another challenge was not being in person. Like Hiwot said, it wasn't like you're approaching a conversation in person. So I think that came with additional challenges where the trust piece really had to come from WACh, who was familiar with some of the interviewers that we were talking with. Yeah, I would just say humility and making sure you're listening was probably the biggest part in approaching those conversations.
I have a question. Thank you both for sharing such great work that you did in such a small time as well, and great quality. Something that came up in both of your presentations was how men were hesitant to your approach and the survey discussions, but also given that youth are also pretty highly affected and they're kind of open. So I was just wondering, how do you see this work moving forward, given that kind of extreme situation of like men and women and youth being on the other end of the spectrum?
yeah, it's a great question. I think it's always like finding. So we were mentioning about like they prefer someone from a trusted faith leaders. I think that's the beauty of Scope. Like that's the strength that we have is working with the church community who are really interested. People will tell to the church faith leaders or the priests is something that they will never tell to anyone. So this young man, the mates, will be more open to speaking, not just me, but to the priests. So using that strong connection with the church community will help us like to interact with them, pass a message. So it's finding that key interest in it.
Yeah, I think Scope's model is probably the biggest point to be leveraged, just so that people are working with trusted leaders. I think it's really important that the actual intervention is being led by local individuals who are trusted in the community, so faith leaders, potentially community health workers, but also elders. I think like who's leading these interventions is probably the biggest part. I was going to say something else. I think the psychoeducation component would be really important as well, to make sure that like people are familiar with what you're talking about before actually implementing an intervention. Like a lot of trainings have been done with faith leaders to just kind of approach having the conversation about mental health before implementing, like Friendship Bench, for example. So I think that would be really important, to do a lot of groundwork and kind of formative connections and conversations before actually initiating something like Friendship Bench.
Yeah, thank you, Hiwot and Brooke, for the presentation. I'm Susan Kulia, visiting scholar from Kenya, psychiatrist. I just want to find out in Ethiopia if they have a national mental health policy, since you mentioned about task shifting, some of the services being shifted to psychiatric nurses. You know, in my country, we have different categories of mental health care providers. So just want to know if in Ethiopia there is a national mental health policy.
Yes, there is. Yeah. This has been like last year a while, but I remember downloading that document that's coming from the WHO, GA. There's a policy. Actually, they have been like, there's a plan to work on shifting like training from the small healthcare post training that almost kind of first aid kind of training. But there's a policy that because of what's happening in the past 5 years, I don't think they have it, but it's in paper. We do have, I still haven't like it. Then I'll go through this one. I remember reading about this.
Yeah, thank you so much, both of you, for your work. That was really beautiful, and some of those quotes are just devastating. So thanks for sharing all that with us. I'm curious to hear what the next steps are. I mean, I think it seems like it's really ripe for kind of co-developing an intervention that could be delivered by faith leaders. And there are, aside from Friendship Bench, there are multiple manualized evidence-based interventions that could be adapted to include more faith elements. And there are people at UW doing that type of work. So I'm just curious what the next steps are. Fellow.
I mean, I think that we're still trying to figure out what the next fellow is going to be doing. And I think intervention of one of these mental health interventions that have been proven to be efficient, like Friendship Bench, would be ideal, but obviously depend on the funding landscape. But I think I didn't talk about this component, but we also did a lot of work with internally displaced youth. And I think that would be a really powerful way to intervene in the future, is maybe see what Friendship Bench or like Plus or another mental health intervention that's been proven to be effective could do for that population, because there's a lot of needed mental health support there. And we did a lot of interviews with them. And I think that given the conflict, there's a lot of younger adolescents who are migrating into Gondar and more urban areas without their families. So I see a lot of need for mental health support in that capacity. But again, I'm not sure the actual feasibility of implementing something. I think it'd be ideal if we could continue that work. I know Healing Hands of Joy also is wanting to combine faith leader training with the Safe Motherhood ambassadors that they have, because that's a very similar model that Scope is doing of pairing faith leaders and community health workers. So I think we're looking to kind of see how our model can help in developing a training for them as well. So I think that's kind of the maternal health obstetric fistula piece a fellow would continue working on, is supporting maybe researching how efficient that model is in training people and actually implementing that model of faith leaders and Safe Motherhood ambassadors. I don't know if you have anything to add to that.
Yeah, I have some thoughts. Katie had a hand up, and I wanted to make sure you get a chance.
Sure. Thank you. So thank you very much. Just to echo everybody's sentiments, really like outstanding presentation, both of you. I had two questions. One was, did anything surprise you in terms of what you found out, in terms of how you went in and started to engage? So did anything surprise you in terms of that? And then it's a follow-up question on Kashet in terms of next steps. Your thoughts about that, and particularly you kind of said one of the things that emerged quite strongly was this idea for a community level, multi-level intervention. And I think, as you also commented, there needs to be a kind of a readiness or the right kind of people able to kind of take this on. And I wondered what your thoughts were about that. Is there readiness? Is there desire? Are there enough of the right kind of people that could take on a community level?
Yeah, started. So in terms of what surprised me is, so there was like a lot of things going on in the conflict, and then I have heard a lot of international organizations getting into this war area, but and I was hoping there's some kind of, intervention happening, especially like with providing something. But talking to the entire 31 individual, they say there's nothing that's good. There's no support. That was like, for me, that was, so why, we like in the news and here and there, but on the ground there's nothing that's happening. The people are like just suffering on their own, just supporting and relying on their, one another, like through the coffee or through talking to the neighbors or to the church. So that was the existing intervention that we found out. So that was surprising. The government is doing nothing, or the international organizations that are there already, but is nothing. In terms of readiness for the community, I think so, because why I say this is like looking at how they are coping, with their coping. That shows it is intervention in its own right. It's not organized, but people are going to the church and talking. They're getting some kind of relief. And then, in our country, we have this culture, like when something happens, we gather, we eat together, or we share, and then we drink coffee. And then through that process, there's healing. People talk about what they feel. So that is intervention on its own. It's not like scaled up or organized, but everywhere, every neighborhood you go, there's this thing. So that means the communities are ready. They don't even know like how, they don't know it, but they are ready. They are doing that. They are healing one another through that thing. So if we have an organized, effective way, for example, the friendship bench, which I believe is already happening in Ethiopia because of the informal process, but that is making formalized and giving them a little bit of training on top of that. That could take us like way ahead. So that's how I see there is readiness and there is support even from the church. The church is, that's how we get this information, right? The church is saying we need help. So we have this issue. How can Scope help us to get this one, up and going? So that's a huge initiative that we see from the church.
Yeah, I think you answered that really well. I don't have anything to add on the readiness component. I think that the need is definitely there, but in terms of what surprised me, I think continuously looking into the global mental health space, I'm always shocked by how little it feels like it's talked about or funded. And I think it should be a lot more of a priority in public health, in the public health landscape, because the need is so stark. I mean, the quotes that Hiwot shared, I think you come across so many stories like that when doing work like this in the community, even if it's like a different, I think that the need is definitely there. And I was also really surprised when visiting Emmanuel Mental Hospital that they talked about how they always have a line out the door at their facility every day. Like hundreds of people come to seek care, but there's just not enough infrastructure. There's not enough support. So I think I was shocked by the actual need that's in the community. I think that ties into the readiness piece. Like people that are definitely seeking support, even though it is a very stigmatized topic. I think there's a lot of serious mental illness going on, especially because of the conflict. So, yeah, hope that answers your question.
I mean, this was, I think, the challenge that we posed to Hiwot and to Brooke. You know, I think mental health needs had been bubbling up even before COVID, before the Civil War, but those were much more like day in, day out, routine mental health capacity needs that were not there. And then, you know, dealing with a much different, much more acute set of needs. And I think one of the things we wanted them to see if we could start to chip away at is like where we can't tackle it all. So where are the opportunities that we can sort of leverage the things that we've done? And you know, I think the faith leader involvement piece has come out, I think, as an opportunity. I'm curious if you guys got a sense of what resources, what training, what support would the priests and other people in those positions need? Have they identified things where they could use some support or use some resources, or any insights that you guys have in terms of like, is there an opportunity for us to scaffold some of the things that are already in place?
I think mostly for the rural areas, the priests they don't have like any formal training in terms of identifying what mental health is. Someone you mentioned about the emails of like explaining the mental health. Someone will say, "I have a burning something." That could be so. There's no way they can say they will always refer you. Let me just pray for you. Which, yeah, prayer will work, but that kind of identifying what are the silent symptoms, that kind of training, and mental health first aid training, especially for the priests back in the rural area. We have priests in Gondar in the town who have a training that nurses their own, so they know that. They know they can refer them, but almost I think 95% they don't have any formal training. So that would be one thing, train them so that they can identify. But not just train them, there should be like a way to link referral pathways to the system. Training them and then they will identify, but they don't have any way to refer that individual, that would be a disaster. So training versus creating that connection with the institution. The idea would be very.
Yeah, that's exactly what I was going to say. And I know that you might know more about this than I do, but I think the Ethiopian community of Seattle does a lot of informal mental health training, so that could be a good kind of space to tap into and learn more about how the training that they're doing could be leveraged in Ethiopia. But yeah, I think recognition of symptoms and then what to actually do. Yeah.
Yeah, hi. Thank you for the presentation. Well done. I just wanted to mention something from my experience. I worked for World Vision for over a decade, and they have I just wondered, with your experience interviewing faith leaders and others, do you have a sense that there are attitudinal barriers and stigma that is basically propagated by the church? I mean, because that's one of the areas that World Vision focused tightly on to try and intervene and change. And I just wondered if you thought that kind of approach would be what's required.
I think this also ties into the question of what surprised me, because I expected there to be a lot of hesitation in talking about this. But I think that because Scope has so many trusted connections, especially with the diocese, that really helps in discussion. And even attending the faith leader training with Healing Hands of Joy on obstetric fistula, they were so willing to help because of the way that you frame discussion around that topic. So if you say this is something that your community really needs and your responsibility as a trusted individual in the community is to support these people, I think then they become very willing. Once you actually kind of broach the discussion of this is important, this is a need that must be intervened on, they're very willing to support in whatever way they can. But I think it really depends on the way that you approach that conversation and demonstrate the need to faith leaders.
So it's less of an issue of hesitancy on the part of those leaders. But once they're given the skills and the information, they're able to jump in the deep end of the pool.
That's my understanding. I don't know if you have anything to add.
I think so, especially nowadays, because it's really overwhelming beyond their capacity. In the old days, it used to be like, oh, if you come with depression, they'll say, hey, well, go to the prayers, go do something. But they know that this is not really addressing that thing. So it's really overwhelming. And for this, the priestess in Gondar, because already Scope has cleared the ways, they are very familiar with, they know how medicine and phase works. So we have that. But you might find some resistance outside of Gondar, which requires a little bit of like training on the stigma sides within that church community as well. But yeah.
I'll also add, like I think Ariana and Brandon mentioned, one of the faith leaders was actually the person to mention that this was a pressing need, and I think that's because so many people are coming to them presenting mental health challenges, especially because the conflict and being displaced and all of the struggle that's been going on. So I think their awareness of that problem and really a desire to want to intervene, but not knowing how to go about that has been really powerful in actually leveraging them to intervene in this topic.
So maybe one other follow-up, which is about the gender-based violence piece. In the experience that I've had with World Vision, the program that they use is most effective when it's stigmatized, hidden behavior like sexual behavior, HIV, reproductive health, these types of things where faith leaders will really do need to have a different sort of framework for shifting their mindset to be able to even open a discussion in those areas. So I'm wondering if, in particular, that gender-based violence piece might be something that requires special attention in that regard.
Yeah, I would say that too, because I was even having very hard time talking to the gender-based violence, even with over the phone, people were like so terrified.
Yeah.
Because that gender-based violence is sometimes could be happened by, the military or something. So they are very scared by them to express those things. I know someone who had this. They won't
say it in the first person.
Yeah.
They'll put it in.
Yeah, that's very tricky. That needs really special blessing. Yeah, that's what I can say.
Yeah, and thank you so much for again laying the groundwork for thinking more about a friendship bench intervention too. Like it seemed promising. It seems like you've learned a lot that it is, and I think there'll be a lot of grant writing in this area. Looking at Diadone moving forward with everyone here support. And I just wanted to put a plug that WACh is trying to bring the developer of Friendship Bench over for the Delve lecture in October or November, which would be another great opportunity for folks in the room who are interested in Friendship Bench. So cross your fingers that visa comes through and we can dive into more of that too.
For coming and congratulations on